This episode of EMS One-Stop is brought to you by Lexapol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexapol.com. That's LEXIPOL.com. Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and today I've got a returning guest, a very welcome returning guest, and that's Dr. Alex Isakov. Welcome, sir.
Rob, thanks. It's always good to be here with you.
It's always good to have you on because as our resident expert in all things infectious and contagious, it's good to have an update. Before we go any further, I know who you are, the regulars know who you are, but just introduce yourself and your backstory.
Thanks, Rob. I'm an emergency medicine and EMS doc at Emory University. I get the headline on communicable disease in the EMS community, I think, for leading the EMS work group at the National Emerging Special Pathogens Training and Education Center. As you may know, we also lead a biosafety transport consortium. That's the agencies that are supporting the federally designated regional special pathogen treatment centers.
Wow, so that was quite the mouthful, but in simple terms, you are my go-to guy when things are happening. But I want to start off by telling you a story before we go into today's discussion. And that really is about H5N1, which I know you want to talk about. And obviously, it's has been emerging. It's here. But way back when, and actually I worked out now, because in fact, there's a Wikipedia entry in this. I'm going to put it in the show notes. So back in 2007, when I was serving as one of the senior leaders in the East of England ambulance service in the UK, we actually had an outbreak of H5N1 at the Bernard Matthews turkey factory. Now, if you're an American, it's Bernard Matthews. And for those that worked with me way back when in the UK will remember this very well, that we had an H5N1 outbreak in the largest poultry production facility in the country. And so there were not tens of thousands, but millions of birds that immediately were at risk. Of course, there is the veterinary issue of putting them down, but also there was the issue of containing, controlling, and looking after the factory workforce. And indeed, that was a major incident where not only in the east of England that I'm certainly sitting next to the police or the chief constable for the area and the chief fire officer and those environmental health people in the command post, but obviously we're briefing ministers up to the Prime Minister because, of course, this is a major national issue. And so from a command and control perspective, that was really an interesting learning moment for me. Not only that, of course, some of the workforce who were immediately under the instruction to isolate, of course, did the great British thing of going up the pub. And then, of course, we had to then don the Tyvek suits and extract them from the pub, which caused all sorts of newspaper, excitement.
Yeah.
And so, I can actually start by saying I have direct experience of this, but that's my story.
No, but it's important. Because your story is particularly interesting because that was really early in the time when it was recognized that this novel bird flu could make humans ill. Yep. It was probably quite noteworthy that it appeared in the shores in the UK. And the way that happened was from birds that became infected in Southeast Asia. They also infected migratory bird populations. And so these birds fly where they want and obviously ended up in the UK causing
I think it was the great British swan. Of course, swans are a protected bird in the UK. They technically belong to the king, would you believe? And so, of course, they are coming, as you say, they are coming from west to east.
Yeah,
and of course
really
that is, and again, that was one of the issues that was a connective piece of this story.
The other real challenge around H5N1 at that time, because so little was known, was that when it first emerged in 1997, among 18 humans that were recognized as having contracted this bird flu, a third of them died. As a human exposure to bird flu back in those days, Rob, when you were dealing with it, was being recorded, the case fatality rate, meaning of the people that were known to be infected with this H5N1 bird flu back in those days, in the late 90s, early 2000s, half of humans that got infected with that bird flu died. So really high stakes, obviously, and every effort made to control the virus. But here we are, some 25 years later, with the ancestors of that strain infecting not just birds, but as we've read, dairy cattle in the United States also.
So that's enough of me telling the sort of the origin story, certainly from my perspective, and actually to pick up on a point you made, because it was novel and new, the level of fear, misinformation, disinformation, lack of understanding was actually exceptionally high. And I think we saw that also the outbreak of the pandemic as well. And so again, that was another deja vu moment for me. But take us back to the origin of this particular outbreak. It's it's sort of its breakdown, what it means to the US, and of course the EMS community need to be thinking about.
Sure. Well, to make it a fairly short story, this bird flu. So as you've heard me talk about before, same as humans can be infected with influenza. There are human influenza viruses that circulate. Pigs can be infected, get the flu. Birds can also get infected and get the flu. Sometimes bird flus or swine flus can make humans ill if they come in contact. And that's what was first reported in 1997 in Hong Kong. Actually, there were 18 cases of 18 human cases of this novel H5N1 bird flu, causing 6 deaths at that time. And as it happens, as a public health control measure, they tried to kill the flocks that were infected with this novel influenza virus because it was known to cause a threat not just to the bird population, but to humans too, but weren't successful in eradicating it. And some 5 years, 6 years later, it emerged again. And since then had taken root in migratory bird populations, and for the longest time was just being identified across Asia, in Europe, and also in Africa. North America was largely spared, but as the virus continued to evolve and involve migratory bird populations, then this bird influenza, this bird flu, was also identified in U.S. bird flocks, where it's now fairly widespread. It's a highly pathogenic influenza virus. What that means, Rob, is that it makes the birds really sick. So flocks of birds that are ill with this virus, they appear sick, which is good for us in terms of trying to identify birds that are affected. It will obviously kill birds, which, so if you're working in the poultry industry, or you're in some kind of work or even recreationally exposed to birds that are dead, that say, well, let's stay away and try and prevent illness or transmission. But what really got concerning for the public health community was then the spillover of this bird flu to other mammal populations. So they started to emerge in populations that would maybe, be predatory be predators of these sick birds. So it would show up in fox and other predatory mammals. It's been demonstrated in mink, for example, also. And then more recently recognized in dairy cattle herds in the United States. And the last 3 cases, human cases of H5N1 bird flu in the United States, were among dairy cattle workers. So they were exposed to cows that were infected with the virus and became ill. Good news for them is that it was all mild illness among these 3 dairy cattle workers in the U.S. that contracted the illness. There was a 4th case in the United States from 2 years prior, actually, that was attributed to actually a worker in the bird industry who was culling sick birds, also got infected. But all mild cases to date, which is good in the U.S.
So this is a bit of a transatlantic crossover today, Alex, because of course you mentioned cows making you ill, and of course that also during my time in the UK, BSE, the infamous mad cow disease, which again it cost a lot of attrition to the national herd as well, and as a result of that, because I come from the UK, would you believe I can't give blood here in the US in case I may have BSE as a result of that, and so whilst I've attempted to give blood, I can't, which is interesting. Any UK citizen. But let's go back to the avian side. And so
Right.
what are the signs and symptoms that a medic should look out for should you just happen to come across someone that may raise an index of suspicion?
Well, it's a good question, Rob. So to date, the 2 cases that had been 2 humans that were infected with H5N1 bird flu in the U.S., Actually, two of them had simply conjunctivitis, or pink eye, basically. They were recognized as they were tested to see what the source of the infection was. They were identified as having an untypable influenza A infection, and when it was sent to the special labs at CDC, confirmed to have this novel influenza virus. And those two cases, very mild conjunctivitis only. A third case actually developed some respiratory symptoms, which is a little more concerning. And the very first case that was reported some 2 years ago had some mild malaise and fatigue. So fairly nonspecific. For the EMS community, I think where this might be of greatest interest is if you're working in a service area or serving a population of people that are working on dairy cattle farms, and working with your local public health department to understand what the risks are that someone might develop signs and symptoms of illness that would prove to be H5N1. But let me raise a couple other important elements of this virus. We talked about a 50% case fatality rate for these ancestral strains of H5N1. The virus has evolved tremendously since then. And we've talked about a number of mild cases in the US. So the case fatality rate for the current circulating strain is not 50%. We would say public health would probably tell you they don't know exactly what it is, but appears, at least in the cases identified in the US today, that it's low. Another important factor for this H5N1 virus is that it's not easily spread from human to human. So while humans that are exposed to infected animals, sick birds, cattle, for example, especially if they're not protected, if they're not wearing personal protective equipment, will be at risk for exposure to the virus and can become ill. When they become ill, the likelihood they transmit it to others is really, really low. So EMS personnel that have any suspicion at all, well, any EMS personnel who are doing their work should be implementing standard precautions anyway, right? So standard precautions is important. And if they have any suspicion at all that someone might have a novel bird flu, we could talk about the details of the personal protective equipment that they would put on to protect themselves from exposure. It's basically, Rob, the same PPE that we saw to prevent COVID transmission during the COVID pandemic.
That's good. And so before we move on, anything else we need to consider or think about in terms of the H5N1?
Well, some of your listeners, Rob, would rightly ask, well, if CDC says that the risk for the human population is low, then why are we talking about this in the EMS community? Why worry about it at all? And I'll give you a couple of reasons for that. One, while this virus has been tracked by public health authorities since 1997, what's really different today that's putting in the news is this spillover into mammal populations, the dairy cattle herds now in particular that we're talking about. That increases the likelihood of exposure to humans, and it increases the chance that humans can become ill with the virus. If EMS personnel are asked to transport a patient infected with H5N1 or suspected to be infected with H5N1, they should know how to implement a hierarchy of controls to protect themselves, know that it's possible to do that, with a high level of certainty, and also recognize that today the chance of transmission between humans is really low. The second reason to talk about it is that we remember what the COVID-19 pandemic meant for us in EMS. There's no one suggesting that H5N1 is going to be the next pandemic, but what we're seeing, the evolution of this virus, the way we've just described, then maybe it's time for us to just reflect on what we were doing during the COVID-19 pandemic and see what we might do to be better prepared should the virus, evolve further, to adapt to humans, to make it more likely that they become ill, and adapt in a way that would allow the virus to more readily transmit, from person to person. So it's a little bit of a warning call to say, let's look at what we did during COVID-19 and take this opportunity to sort of review our policies, procedures, and get our act together.
I think that's a good final thought for this segment of the show, is that, it's easy to forget. And of course, I'm sure that lessons that we identified during the pandemic are already fading into the distant sunset, and so obviously a good chance just to brush off the manual pamphlet and obviously reread everything that you need to understand. But for the minute, let's just take a word from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
Thank you for that, Reed. Don't forget that you can please like and subscribe. Also, this is a podcast and a vodcast, so we're going out on Apple Music, and also we're on YouTube, so you can see us and hear us, or see us and hear us. And of course, the advantage of following us on YouTube is that we can put up some graphics, some charts, some graphs, and you can kind of follow along with the discussion. So here with my good friend, our good friend, Dr. Alex Isakov. Thank you for joining us. Obviously, he's our go-to guy on all things infectious and contagious. Alex, welcome back, and thank you for joining me. You mentioned the hierarchy of controls. So by way of revision, why don't you go over that for us?
Yeah, sure. Thanks, Rob. So identify, isolate, and inform is important for any special pathogen. I think for H5N1 in particular, if you're again serving a community that is maybe at higher risk for exposure because they're interacting with dairy cattle, if they're presenting with flu-like symptoms or pink eye or conjunctivitis, that would be maybe your first clue that you should take additional precautions. So among the additional precautions is to know what kind of PPE ensemble to wear. Like I mentioned earlier in the segment, the PPE ensemble that we wore to protect ourselves from SARS-CoV-2, which causes COVID-19, it would be appropriate. So standard precautions, plus contact, which means some type of gown and gloves, plus airborne, which means an N95, fit-tested N95, NIOSH-approved respirator, and eye protection. Usually a face shield would be ideal. So if, again, you suspect that someone might have a novel influenza virus, H5N1 is the one we're talking about, but any novel influenza virus, standard precautions plus contact, which is gown and gloves, N95 respirator, and a face shield would do it. And I'll tell you, there are other things that if you go to the NETEC website, we can refresh your memory on. It would be ideal if you limited number of personnel that were making patient contact. It would be good to separate the driver compartment from the patient compartment, turn on the exhaust vents, make sure you're circulating fresh air into that compartment, avoid aerosol generating procedures if you can. And if you do need to implement them, ensure that you're really, using the PPE ensemble correctly to protect yourself. That's what would be important. Couple things to make the audience feel more comfortable about this, which is, I think, important. Reiterating again, less likely to be transmitted from human to human. And the previous cases that we just talked about, the 3 cases that were recently identified among dairy cattle workers treated with oseltamivir, an antiviral medication, and everyone recovering, which is good. Rob, if I could, I'm gonna try to just package some of what I've said in a way to answer a question that we've been asked in the EMS community. Is the EMS community ready to transport and manage patients infected with H5N1 today? And today is June 24th. I'm going to give you a qualified yes for a few reasons. One, it's so far the cases reported among people in the United States have been mild. 2, it's not easily transmitted at this point from person to person. 3, the EMS clinicians in the field know how to apply the hierarchy of controls, including that PPE ensemble that we've described, because they've gotten a tremendous amount of experience doing it during the COVID-19 pandemic. For me, those are all reasons why the EMS community today is ready to manage and transport a patient with H5N1. If this evolves to a disease that can be easily transmitted from person to person, then all the complications associated with managing patients during a pandemic come into play, which is particularly challenging for many reasons, and we all experienced it through COVID-19.
We did indeed, and we don't want to go there again, but obviously we've now had that recent experience, which hopefully helps us prepare as we think about this. So let's just sort of go around the world, and obviously one of the things that you do is you're monitoring global trends and issues and emerging, as you say, emerging pathogens. But what else is out there that isn't necessarily here, but we just need to keep an ear and an eye on?
Well, it's great question, Rob. So you know that there's always active monitoring to discern if there was an Ebola or a Marburg virus disease outbreak. There's no current outbreak of Ebola or a Marburg virus disease, which is good news, but there will be again. And when there is, it'll be important for the health departments where that outbreak is occurring, historically not starting in the United States, but endemic areas in Central and West Africa to control it. And we would then need to be alert for a returning traveler with signs and symptoms of that viral hemorrhagic fever. We've talked on this on your show, Rob, about the disease Mpox caused by monkeypox virus. And we've talked before about different strains or clades of monkeypox virus. There is an ongoing outbreak in this Democratic Republic of Congo of the clade 1 monkeypox, which causes the most serious disease with case fatality rates reported as high as 10%. If someone in the EMS, there are no cases of Mpox caused by clade 1 monkeypox in the U.S. today. But if you were to have someone recently returned from the Democratic Republic of Congo who presents with a fever and an unusual rash or lymphadenopathy, meaning swollen lymph nodes, that would be reason to say, I'm worried this person might have Mpox, and then implement the appropriate infection prevention measures and notify the appropriate authorities. In particular, let other responders know, and whatever hospital you might be transporting them to, let them know you suspect Mpox in that case, so that they can also implement the appropriate hierarchy of controls, wear the right PPE, and take the right precautions.
And I think that's actually a good message, not only for, we talk about the medics on the truck, but obviously this is one of those call taker moments when you're interrogating somebody. Their travel history is important, and actually being able to then connect the dots of our DRC, Democratic Republic of Congo, coming into, and I remember back in the Ebola days, we had someone that had been tracked in from sort of the west coast of Africa through Dulles, and was on their way down I-95, and we set up this rather elaborate method to intercept them at the Greyhound station, and of course that caused all sorts of issues with news reporting and coverage and everything else. And so being aware of this at the call center is also key. It's not just for the medic on the truck, and obviously there's probably lots of resource that people can go to, and anything that we've talked about today, of course, we'll put in the show notes. But of course, this is information for not just the frontline medic, but obviously those that are commanding and controlling us too, right?
Yeah, no, it's absolutely right. We've always said that the emergency medical dispatch program is a great opportunity to help the EMS community screen for patients that might have a high consequence infectious disease, so that they can alert them to take the appropriate transmission-based precautions. I agree.
Good. Well, we've both agreed that you will be, like it or not, a returning guest on the EMS One-Stop, and you're back again. I'm sure we'll have you again in the future. But
I love being on your show, Rob. You got a great audience, and I love the opportunity to talk about these things with you and share what we know and make the EMS community better ready for communicable disease threats.
Thank you, and we're really happy to share your information. But for the minute, though, my classic Rob ending question: is there anything I've forgotten to ask, or anything you need to tell us, Alex?
Oh, nothing that should be on the air, Rob. We'll have to take that offline and explore it together.
Okay, well, this is a family show, and my guest was Dr. Alex Isakov. And Alex, thank you so much for joining me, and I hope you come back real soon.
Thanks, Rob. Appreciate the time.
Good. As mentioned, please make sure, A, you like and subscribe. B, all of the issues that we've talked about will be in the show notes. We look forward to seeing you again very, very soon. So thank you to Dr. Isakov. This has been EMS One-Stop. I've been Rob Lawrence. Like and subscribe. And until next time, bye for now.